Our next speaker is Dr. Emma Miller. Emma has been a Senior Research Associate at the University of Strathclyde since 2012. Emma has a background in social work practice and interagency working. Since completing her PhD in 2004, she's worked between research, policy and practice on the theme of personal outcomes. Based on knowledge exchange and action research, this is focused on embedding an outcomes approach to practice and has involved partnership between a wide range of national bodies and local organisations to reorientate culture, systems and practice accordingly. That's a bit of a mouthful.
Well done.
The primary purpose of this work is to support outcomes focused on person-centred engagement at the front line, with the secondary purpose to measure outcomes and to use this information for service planning and improvements. So, and I promise I'll do better all the time.
Okay, thank you. Just to start by thanking Zoe, Liam and Kevin for organising today, and it's been a real pleasure to get to know you all through the Eurocaders in the last few years, and I really appreciate the Irish connection, particularly in the last year I've managed to get my Irish passport to complement my UK passport. I'll not mention why, I think you can all guess. And also to say thank you very much to Ronan and Nikki for setting the bar so high with your presentations, a hard act to follow. But I'll try to be quite brief in talking through what is not really so much research focused presentation as more describing a long-term programme of knowledge exchange and a kind of unrelenting negotiation between research, policy and practice since 2006 on the theme of personal outcomes. There's something about being a Rottweiler and sticking with your topic in all of this. So I wanted to start with a quote which is not actually from a carer, it's from a young person. We recently did some work in secure care centres in Scotland, working with young people who are seen to be particularly high risk. And this particular young person had a beautiful way of using metaphor to describe difficult situations, and she came out with this quote, which was, "Sometimes the river is too wide to cross and sometimes you need a lily pad to get you over." And I've kind of stuck with that quote because I think it describes all of us at different points in our lives, and I will come back to that at some point in the presentation. So although I've said I'm not going to talk an awful lot about research in terms of methods, etc., I think it's useful just to acknowledge that the work on personal outcomes is based on long-standing programmes in several countries, and I feel obliged to acknowledge the work by the Social Policy Research Unit at York University, who did 10 years of work on outcomes that matter to people, that is service users and carers, from 1996, and they really laid the foundation for the work that's subsequently been done elsewhere, particularly in Wales, in Sweden, in Canada and in Scotland, where we're still working away on how to make this work. Some of the things to say about the work that Sprue did at York University, I think it is important that they looked at outcomes, or the things that matter to people who use services, and slightly separately, the outcomes are things that matter to carers, because actually they give us two frameworks of outcomes, some of which are the same, some of which are distinct, because outcomes for carers are a bit different, but they give us a way of thinking about what matters to people that potentially we can think about what matters to families, and some distinctions within families that can be quite helpful too. I guess some of the distinct outcomes for carers are around managing the caring role and being treated as a partner. I think one of the presentations this morning is absolutely critical of carers being treated as partners by services, but also the quality of life for the carer, because I think all of us who work with carers know that there can be a real tendency for carers to focus on the quality of life for the cared for person and actually forget that they had a quality of life, or even to recognise that they've lost that quality of life, and so how important that is to keep that focus. I guess another key thing about this thing about focusing on outcomes is that what we're trying to do is shift away from focusing on what are the, and I know this as a recovering social worker, that there can be a terrible tendency to focus on what is wrong with the person, what are their deficits and their shortfalls, and what can we put in to fix those deficits. And actually what we're trying to do here is flip that round and focus on where does this carer want to get to, and that can involve quite long, detailed conversations over time because they've forgotten. what would a better life look like, and how do we work together to get there? So it's not just about how we fix them, but how we draw on and enable their own strengths, as well as how we work in partnership to get there. So it's about focusing on the intended impact, and some of the social workers in particular we've worked with have said it's like working backwards. So instead of going, what are we going to put in, it's a where are we trying to get to, and what do we need to get there, and that is a shift. And one of our key models or diagrams that we find really helpful in illustrating that is the exchange model of assessment, which signals moving from question and answer, or a more interrogative form of interaction, to an exchange, and I'll show you that picture in a minute. But first I wanted to show you this diagram, which is based on one of our local equivalent of a HSC, is it you call them local? It was the equivalent in Scotland, East Renfrewshire, and they wanted to signal to practitioners we're moving from a very detailed prescriptive form filling approach. Some of our single shared assessments ran to 50 pages in the past. So we're moving to having a conversation loosely shaped around the key things that we know that matter to service users and or carers. So some of the examples here, so the 4 types of outcomes for carers are managing the caring role, well-being, having a quality of life, alongside caring, being treated as a partner by services, and the quality of life of the person they care for, as mentioned before. And these are just some of examples of those types of outcomes. And financial well-being, as you'll see, is included in there, reflecting in some of the, and that's been an increasing issue in Scotland, the same as it is in Ireland over the last 10 years. Coming back to the exchange model of assessment, we find that this is particularly helpful for practitioners in terms of thinking about we all bring our own expertise and knowledge to the table, and it's not about, and there's something fundamental about this, and again speaking as a recovering social worker, there's something about the liberation that comes to practitioners of not feeling that everything this person identifies is my job to fix. Because when people are afraid of that, they're less likely to open up the conversation. They're more likely to keep the conversation closed to the areas they feel they have control over, and it's through benign intent but with negative consequences. So this exchange model is trying to clarify that everyone is bringing something to the table, and the original model was from Smale from 1996, but we've slightly remodelled it because we're looking at a much more multidisciplinary world now. So it's about different practitioners potentially being involved and contributing to the same outcomes, and also different organisations as well. And I've put up there, we do have evidence of the benefits of this way of working, and I've kind of summarised them around the edges of that model there. And I suppose one of the things that it's worth mentioning at this point is that, and what I think has been lost in a lot of systems, and looking at other countries as well, the same thing seems to apply, that the benefits of interaction and good conversations in their own right are not really valued by our systems, but actually those conversations are fundamental to well-being, to getting the right support for the right people, and loads of other benefits as well, and yet where are they in key performance indicators? Not there. So I think we've got some way to go on that, but certainly the evidence is there about the benefits of that. And for organisations, there is the bit about, working like this does result in better outcomes for everyone, more effective use of resources, and there is that bit about shared responsibility. It's not about taking responsibility away from people, it's about sharing that responsibility. So, just switching a little bit from, I'm sort of hurtling through years and years of work here and trying to encapsulate it in really accessible ways. So I hope it makes sense, because I'm now hurtling from the conversation to what happens when you go to write that conversation down in a support plan or an assessment. And one thing I would say is we've moved away in Scotland from talking about assessment to talking about support planning for carers, because we found that carers can find the word assessment quite intimidating, quite often think that they're being assessed as to whether they're effective or not, and so on. So we've moved to talking about support planning. And so we did this big project a few years ago called Meaningful and Measurable, which I'll only talk about the recording aspect. All 8 organisations who participated came up with 5 key criteria for what you would look for in a good outcome-focused plan. And the criteria are that you would want to see outcomes, as in what is it the carer wants to achieve, not just a list of outputs or services. you want to understand what is it that's important to the carer, what are we trying to achieve here. Also that the outcome should be personalised, because one thing that was happening in services was practitioners were starting to organise outcomes, but they were the same for everybody. So if a carer is saying, I want to feel, I want to look at my well-being, well, what does that tell you? Absolutely nothing. You need to know what is it about this carer that they want to specifically focus on. So personalised, that the person or the family should have a role acknowledged in the plan, because people are doing things they're achieving fantastic things despite phenomenal challenges, and we need to be acknowledging that in writing, and it matters to carers when they see that their role is acknowledged. And also another thing is that there's a terrible tendency, and I did it myself as well, to feel you have to professionalise the language used in a support plan. So things, a simple phrase becomes phenomenally jargonised and removed from the person. So using the person's own language actually has really beneficial effects in its own right as well. And finally, that the outcome should be action oriented. We're not just writing down nice things that the carer says that is important to them, but what are we actually doing to get there? So that's a little bit about the recording, and here's just some very simple examples of carers' outcomes, I suppose, to illustrate we're not talking about writing War and Peace here. These are some young carer examples in there as well. Okay. And also now, having covered conversation and a little bit about recording, I'm going to hurtle on to talk a little bit about measurement, and back to the project of Meaningful and Measurable, which involved the organisations, including carer support organisations as well as healthcare and social care organisations. I've pulled out 3 key messages from that project, and I think the first one is pretty critical and allowed us all to have a big sigh of relief, because when you're talking about outcomes for people or outcomes of any kind, you can't really talk about attribution in the messy world of human beings and their lives. It's impossible almost always to say a specific intervention was the one and only thing that caused this effect. But when you start to talk about different contributions, it opens up different possibilities. And we've actually got quite a lot of tools and techniques that enable that to be tracked, which we're more than happy to share with people. But that bit about contribution also allows for the carer's contribution towards outcomes to be acknowledged, and for different agencies, as I said before, to contribute to the same outcome, if that makes sense. So the second point, so I suppose the second point is, because of that and other reasons, it's very difficult to specifically measure outcomes. So we've started talking about tracking outcomes. So the carer says, I want to be able to sleep at night. I cannot go on unless I manage to get away of having some rest. I'm at the end of my tether. As you go over time, it's checking back with that outcome. You told me a few months ago this is how you felt. Where are you with that now? We tried a couple of things together. How's that working? Is anything made a difference, or do we need to review the outcome? Whereas before, I think we tended to focus on the service. Is there enough of the service? So it's looking at the outcome as the way of making decisions. And I suppose also really importantly, the project called into question the implicit measurement assumption that a higher score is always necessarily better, and that all aspects of outcomes need to improve. That's just not the case. And actually that's why Sprue back in the early days talked about maintenance outcomes. So that was about being able to maintain a quality of life despite the deteriorating condition of the person you care for might be a phenomenal achievement, or even sometimes slowing the rate of deterioration despite phenomenal complexity is really important. So we need to have a slightly more nuanced understanding of increases and decreases, etc. So just coming on a bit more to think about implementation and how phenomenally challenging that is, because I can tell you when we started this work in 2006 with the joint improvement team of the Scottish Government, we all had a really naive assumption that we were going to develop this fabulous outcome-focused tool, and it would be rolled out across the land, and everyone would implement the same tool, and we would all be outcome-focused. And here we are, 2019, and we're still wrestling with the complexity of systems and constantly moving around trying to reorient bits of the system to help this to happen. And I guess one of the key features in terms of thinking about organisations, the culture, the systems and the practice, is that tension between thinking about outcomes as performance indicators, so how many minutes? 5. Reporting outwards, and how challenging that can be depending on the kind of predominant pressures to report, or using information to feed back inwards. So for example, I was talking about financial wellbeing. One of our carer organisations a number of years ago started doing this and realised that what carers were talking about was financial stress. And so they changed their organisational outcomes, and then they changed their way of doing business so that they made sure that was built into their processes. And one of the key things, I think, is to think about what are the supports that staff need within organisations to be able to work like this, because training on its own doesn't work if your prevailing systems are cutting against the focus on outcomes. So we've got lots of work on different approaches to supervision for staff, both in health and social care, and lots of nice tools and bits of work that we're happy to share as well. And I guess one of the phrases that we hear people talking about a lot is modelling an outcomes approach. So being strengths-based in the organisation, acknowledging that staff, when they're, what are their strengths, what are their capacities, what are they doing well, which doesn't really happen very much in Scottish culture. I'm not sure about Irish culture. And also, I suppose, listening and staff feeling listened to, being absolutely essential if you want staff to listen to the people they are supporting. And this is a wee diagram that I drew last week for a presentation in Scotland, because I was trying to get this concept across. So we had a day of working with lots of organisations who've been doing this for a long time, and I wanted to acknowledge that actually if you're focusing on outcomes, you're kind of often swimming against the tide of other cross-cutting pressures that are coming through, and some of them have been touched on this morning. Stuff around eligibility, risk assessment can be counterproductive, but they can work together. You just have to put the effort in to do it. And of course in Scotland, the NHS, we've got massive focus on targets. So I think that's probably enough about that. And I suppose, yes, to tie that back into the point about that is that those features influence practice, and when practice is taken away from the conversation, the lily pad gets lost that we talked about at the beginning. And I've not really got time to go into one of the resources that we've produced recently, which is to support implementation of the Carers Act in Scotland, is specifically geared towards health staff, and it's been designed to try to troubleshoot some of the anxieties that practitioners have about having conversations with carers. I don't have the skills, I don't have the time, I wouldn't know what to say, I don't want to bring it up in case I upset the person. So we've tried to bring in some reassuring messages about how you might work around some of those concerns. And as always happens, you find out if you go out into practice land, service land, you will find people have produced phenomenal resources that really help. And North Lanarkshire Carer Centre have produced this wonderful tool. It's like based on a model from NHS Lothian. It's emotional touch points, and they've specifically designed it for carers so that to help carers to have a different kind of conversation, and there are both positive emotions and features in there and negative emotions. And carers are encouraged either individually or in groups to pick the emotion cards that reflect their feelings. And what they're finding is that it's opening up very different types of conversations with carers. Some of the positive ones have been deliberately put in there to acknowledge carer skills and things that they've gained as a result of being a carer. So for example, patience, compassion, listener. but they found one of the support workers talked about one carer they worked with for years who they saw as being unusually confident and together and businesslike. And when they used this tool with her, she acknowledged for the first time that she felt utterly worthless, and this had been going on for years, so they've changed the way they engage with her. And then I can't really go into details about this, but I suppose the key point is that I think this has been reflected here this morning as well, that a lot of professionals are also carers. And I know that's obvious, but actually it's not obvious to a lot of professionals. And what's happening in doing this work around the Carers Act, we're going around speaking to groups of professionals, practitioners, and they're coming up at the end of the session saying, I actually think I might be a carer. And that just highlights how much work we've still got to do in terms of carer recognition, and that's a whole I could speak about that for a whole day. So I'm really sorry I can't read out Kevin's example, because it's part of a really lovely story about a professional who talks about his own caring experience for his partner, who had a short prognosis from being diagnosed with cancer, and his 12-year-old daughter. And it's a lovely story of his journey through services and knowing what he does as a professional now, looking back. And he actually designs his own outcome-focused plan at the end of that story, which I'm happy to share. And this page is really just to show that there is some evidence, and we've done the academic thing, and we've got some publications. And finally, some resources. We've got, I think Liam already included the website, which really needs an update, and I will get round to doing that soon. And and just contact details. So
yeah, well done, Emma. Thank you very much. So again, thank you very Emma. I've taken a whole page of notes, a bit like Nikki's as well. A huge amount of valuable information there. And again, opening the floor, we've got about 10 minutes for questions, and then we'll have one more presentation and then lunch, which the smell is starting to come in and we'll all be getting hungry. So just open the floor. Anybody has any questions or comments or observations for Emma that they'd like to share? Yes, go ahead, Jack.
Hi, it's really interesting. Actually, all the speakers this morning have been very interesting, so thank you very much. I was really interested in terms of when you talked about the different outcomes for different stakeholders, and I suppose from disability, obviously that is the ongoing perennial question in terms of the relationship between disability and carers. We would have done some work in the past around service providers and people with disabilities, and it's the same idea. So I suppose the question I'm asking is that when you talk about outcomes, and outcomes for different stakeholders in and around caring, so the person with disability, the carer, the service provider, the funder, whatever it is, whoever it is, have you found different ways of having conversations that help to bring a focus to shared issues? Does that make sense?
So
because oftentimes the issue is that people have competing ways of trying to talk about shared concerns, and I then can see that's a theme that I'm bringing up repeatedly today, and it's definitely one for like I'll give you an example for parents who are aging, looking after someone with a disability, and the need to transition to more sustainable caring. That's both driven by the person with disability's own desire for what they want in terms of independence and location, and supports the parents' right to age without having a care. So I'm just talking about, they're all very complex issues, and I'm just wondering if any of that came up in the research.
So
it's really helpful.
Just to repeat the question,
Yeah.
sorry. So in a nutshell, and correct me if I've missed anything, the question centres around the different outcomes for different stakeholders around the cared for person. And the question is really, when you talk about outcomes for different stakeholders, have you discovered or had different ways of having conversations that elicit shared?
Rubber synopsis.
Yeah, I mean it's a huge issue, and I guess that's where the sort of exchange model's at the heart of that, kind of bringing together the different perspectives. But what we find, it depends as well who you're talking about. So if you're talking about practitioners, it's the same as person-centered. There's a lot of similarities between this work and person-centered care. This work is much more explicit focus on making sure that you get the voice and the priority of the person or the family. But the same challenges apply in that anyone who's doing the implementation work within an organisation or is trying to take this forward, we find that all practitioners will say, but we do all of that already, because people believe that they're being person-centred, and that's what makes it, one of the things that makes it so difficult. And to give you an example of my epiphany, and talking about being a background of social work, when we did the original research for the Department of Health, I had not long come out of social work, and I was quite cocky. Oh, we're going to interview people with learning disabilities, people with mental health issues. That's cool. I've had hundreds of these experiences before. So Ailsa and I both went out and did interviews, and Ailsa came from a purely research background. And I looked at our transcripts of our interviews, and I thought, what is wrong with my interviews? Ailsa's getting these really full pictures, and mine are much more limited, and again and again and again. And I realised that I was doing, even though I wasn't in services, I was doing service-led interviews, where I was trying to work out where do people fit into service land. And I guess that's one of the things we've recognised over time, everyone would say the same, is that you need to come at this from different angles. And that's why you need to change the conversation in the organisation. You need to change it in supervision. You need to use videos. You need to examples, get people talking. And some people will get it straight away, and others it's just going to take a longer time. So it's like that kind of coming at it from different angles. So that answers one bit of your question.
Yeah. Yes, yeah. Go ahead.
I'm Celine from the City of Dublin Education and Training Board. We work with youth services in Dublin City. So I was interested around the outcome piece for young people. And have you had, I suppose, much experience in your work around looking at how you measure the outcomes for young carers?
So the question just is about looking at how young carers and outcomes for young carers are measured, and whether you've had that experience in your work.
Yes, so I suppose a similar issue applies in relation to measurement. In Scotland, we have our national framework for children and young people is called Getting It Right for Every Child, and the indicators are SHANARI, safe, healthy, active, and so there would be slightly different approaches to measuring outcomes in different local authority areas. Some using kind of more well-being wheel type approaches. But again, I suppose we would be fairly cautious in purely counting the outcomes for children, that we would be encouraging looking at some of the qualitative data as well. So to give you an example of where that can give a misleading impression on an individual level, I'm thinking about one carer who had scored herself 10, she was only 10 years old, scored herself 10 on that wellbeing model for responsibility, and was really chuffed with that and proud of it. But actually, as a result of that, a lot of her other indicators were really poor because she wasn't achieving and lots of the other things. So if you aggregate that up and the same story happens multiple times, then you're getting a false impression. So it's what was it one of our partners said, using the numbers with caveats and not in isolation from other data. Yeah.
Okay, we've time for one more question or comment or observation. So I just had one actually, if that's just while there's a bit of a Arctic landscape of questions there. I just actually found your point about contribution, not attribution, was really, really in a way transformative around thinking about how services and interventions can benefit people. And I just think that it was a really important almost aha moment or eureka moment about how we can really start documenting in all kinds of work with carers and with service-led, thinking about it differently, that we don't have to be the be-all and the end-all.
Yeah.
Though if we each make a small contribution towards improving life and improving services and improving well-being, then cumulatively it should lead to the outcomes that the carer themselves has identified. And I think the language was just very important, like questions like, what would a better life look like? Instead of, how do I, so it's much more conversational, as you said. And I think those elements are just so important, for our own services here in Ireland. So thank you for your
Okay.
So thank you, Emma, for your time.
Thanks.